Good morning to all. Today's topic for discussion is on furcation involvement. So before going into furcations, we'll just know the basic anatomy of maxillary and mandibular molar and also premolars. So you all know that what a furcation is. Furcation is nothing but it is the area where the roots of a multi-rooted tooth divide or separate. So molars are the tooth which are most commonly or widely prone to infection with periodontitis, as well as almost all other infections. The reason behind which is involvement of furcation area. And that is also the another reason why the highest rate of periodontal destruction is seen if the disease is untreated. And also molars are the tooth which suffer the highest frequency of loss for periodontal reasons. So I've told you what furcation is. So what is furcation involvement or furcation invasion? It is the invasion of bifurcation or trifurcation of a multi-rooted tooth by periodontal disease. So to see the anatomy of maxillary molar, you all know maxillary molars have three roots: mesiobuccal, distobuccal, and a palatal root. So basically, three furcations are present. Between the mesiobuccal and distobuccal root, we have the buccal furcation. And between the mesiobuccal and the palatal root, we have mesiopalatal, and the other side, the distopalatal furcations. Coming to the anatomy of a premolar. A maxillary premolar, first premolar is the only premolar which has got two roots. We have a buccal and a palatal root. So two furcations, mesial and distal furcation. And a mandibular molar, we have two roots. That is a mesial and distal root. So we have two furcations, buccal and the lingual furcations. Now certain terminologies related to furcation involvement. In this picture, we can see an important terminology called as root complex. This is the entire root complex which consists of two components, root trunk and root cone. Now, what is root trunk? It is a distance from the CEJ to the divided portion of the root. And what is root cone? This distance that is from this divided portion of the root to the tip of the tooth root. That is called as a root cone. So here to here is a root cone and here to here is a root trunk. So the together, that is root cone with root trunk together forms something called as root complex. Now what is fornix? Fornix or something called as the entrance. It is actually the roof of the furcation. Now degree of separation. What is degree of separation? Degree is always an angle. It is the angulation of separation between the roots of the multi-rooted tooth. And what is divergence? It is the distance between the two root cones or the distance between the two root tips. Now what is coefficient of separation? Coefficient of separation is nothing but in this picture, it is A by B. Now, what is A and what is B? A is, that is a root distance from the bisecting area of the root till the tip of the tooth root, that is A. And B is something from the CEJ till the tip. So, B is nothing but it is the root complex and A is nothing but it is the root cones. So, root cones to root complex, that difference is called as coefficient of separation. Now, what is the etiology for furcation involvement? Always, the initial or the first etiology is bacterial plaque and inflammatory consequences from the long-term persistence of plaque. We also have other local anatomical factors or considerations and predisposing factors. What are the anatomical factors? Anatomical factors are always related to the tooth root itself. That is the root trunk and we have the entrance root. Now, we have two teeth. See the first teeth, it has got a shorter root trunk. So the second one, it has got a longer root trunk. Now, what is the difference? In this, because the root trunk is too short, that less amount of attachment loss is required for furcation involvement. That is, early involvement of furcation will be there. But here, this much amount of attachment loss is required for this furcation to have. So it takes more time for furcation involvement. But once a furcation is involved, this tooth can be easily treated because accessibility is better. Here, the instrumentation is difficult. So, the prognosis after involvement with furcation is always poorer for this tooth. Secondly, root length. Root length always related to the degree of attachment. Longer roots have more attachment. So, more time will be required for furcation to get involved. Next is root form. Root form is the form of the root. That is, the mesial root of the mandibular molars and the mesiobuccal root of maxillary molars have curvatures. That is, any deviation from this normal form, it can affect the involvement of furcation. Also, fluting which is present on the distal side in the apical third. Next is interradicular dimension, that is the distance between the roots, that is degree of separation. If it is widely separated, we can have easy instrumentation. If it is fused ones, instrumentation will be difficult. Now, always this entire furcation anatomy is a complex one. We have various abnormalities, for example, concavities in the inner aspect. So what happens is the local factors, plaque, calculus get attached to it, instrumentation becomes difficult. Then we have something called as bifurcation ridges, accessory pulpal canals. See the picture, you have multiple extra or accessory pulpal canals which cannot be always located. So these are all pathways of communication between the pulp and the periodontium. Now we have another important factor that is called as cervical enamel projection. It is classified by Master and Hoskins as grade 1 to 3. One is CEP from extending from CEJ towards the furcation. 2 is approaching the furcation. 3 is into the furcation area. Similar to the cervical enamel projection, we have something called as enamel pearl also. These are all areas where the local factors are accumulated and instrumentation becomes difficult. So there are chances for furcation involvement. Now, other reasons for furcation involvement in isolated molars. First is related trauma after occlusion. And secondly, we have certain local or tooth-related factors like pulpal periodontal disease. We have iatrogenic factors and root fractures. Now, what is the role of TFO? We all know the axis of rotation is different in a multi-rooted and a single-rooted. In a multi-rooted tooth, the axis of rotation is always at the bone area between the furcation. That is one reason. Secondly, the periodontal ligament between the crest of the interfocal area and the dome of the furcation is aligned in a horizontal than in a vertical plane. So even a slight increase in the centric occlusion forces will have a crushing effect onto the periodontium. This is another reason for isolated molar furcation involvement. Coming to classification, we have a number of classifications based on horizontal component, vertical component. Important of which is Glickman's classification. Then we should know Tarnow and Fletcher's classification. So what is Glickman's classification? It is based on horizontal component. Glickman says that there are grade 1, grade 2, grade 3, and grade 4 furcations. Grade 1 is an incipient lesion. You can see and normally felt as a catch with the probe. That's all. We don't have any radiographic findings. So basically, treatment for this is just a scaling and root planing, remove the local factors. Now, what is grade 2? Grade 2 is also called as cul-de-sac. Cul-de-sac means the dead end. That is, we have bone loss on one aspect of the furcation, but it doesn't reach the other aspect, which is bone loss present only on one side. So if there is such a case, it can be, may or may not be seen in the radiograph. After our scaling and root planing procedures, we reevaluate. If required, we can do a localized flap and place a bone graft and regenerate the lost bone in that area. Now, what is grade 3? Grade 3 is called as through and through. That is, bone loss is there on both aspects of the furcation. So when we pass a probe, the probe comes out from one side to the other side. It is a through and through lesion. But the furcation area will be covered by soft tissue. So the treatment options in such cases, if it is a not an advanced case, we can even try for regeneration. But if it's an advanced case, too much of interradicular bone loss means we have to carry it with procedures like hemisection or root resection, however, to obliterate or eliminate the furcation defect. Okay. Now, what is grade 4? It is very similar to grade 3, but along with grade 3, if we have soft tissue loss and furcation is clinically visible, then it is called as a grade 4 furcation case. Most of the situations, a grade 4 involved furcation to go for extraction. Okay. The picture shows grade 1, grade 2, grade 3, grade 4. Another classification is given by Tarnow and Fletcher based on the vertical component. It is given as subclass A, B, and C. A is 1 to 3 millimeters of bone loss, vertical component of bone loss in the furcation area. B is 4 to 6 and C is more than 7. This measurement is taken vertically from the roof of the furcation to the base of the removed probe. How to diagnose furcation? Clinically, diagnosis is using a probe called as neighbor's probe, which markings are 3 to 6 and 9 to 12 black band. Always, radiographs are used as an adjunct to the clinical diagnosis, not a single diagnostic method. Always, along with the clinical diagnosis, we can use radiograph to confirm our diagnosis. So, neighbor's probe, if the probe black band is going inside, it shows there is furcation involved. Now, how to probe a maxillary and a mandibular tooth? We all know maxillary molars. The mesial furcation is located on the parietal side, more on the parietal side. So, it has to be probed from the parietal aspect. Whereas distal furcation is located midway between the buccal or the palatal rooms. So we can either probe from the buccal side or from the palatal side. Premolar furcation probing is normally difficult because of the anatomical variations in the premolar. See the radiograph. This radiograph shows a radiolucency in the furcation area. It means there is furcation involvement. We have to confirm it clinically. There is a criteria put forward for furcation diagnosis radiographically. The criteria states that slight radiographic change in the furcation area should be investigated clinically. Diminished radio density in the furcation area in which outlines of bony trabecular are visible suggest furcation involvement. Whenever there is a marked bone loss in a single molar root, we assume that its furcation is involved. Now we have something called as furcation arrow, which is seen in the radiograph as radiolucent areas on the near the CEG of the tooth. It is a triangular radiographic appearance, normally called as furcation arrow associated with maxillary molars on the proximal aspect. Now the treatment part, I've already started with the treatment part. It is basically depending on the type and nature of furcation involvement. Initial treatment is always to remove the local irritants, that is by doing a thorough scaling and root planing. And then depending on the grade of the furcation, we can go ahead with the further treatment. That's all for today's discussion.